Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Today, I talked to Dr. Mike Rose, a pediatric resident at the Johns Hopkins School of Medicine, about the recent surge in respiratory hospitalizations in kids. We talk about a concept called immunity debt, which could explain why we are seeing so much illness now, after years of masking and distancing to stay as healthy as possible during the COVID pandemic. Let's listen. Mike Rose, thanks so much for joining me.
Thanks for having me. Excited to be on the podcast.
So you are a pediatrician at Johns Hopkins Hospital, and I wanted to ask you what things look like right now in terms of respiratory illnesses.
Thankfully, I would say things look much better now than they did 2 months ago. We had a tremendous surge with RSV, was quickly followed by a really big surge of influenza. RSV has certainly abated. Flu is starting to slow up a little bit. Now we're starting to see COVID climb a post-holiday period here. Overall, it's been a tremendously busy fall and early winter, but things are in a much better place today than 2 months ago or so.
So why did this happen? Why have you seen so many sick children you typically would see?
That's a great question. I think the most likely reason, because it fits most with our understanding of viral illnesses and makes a lot of sense with what's been going on and is most consistent analyses, is likely that we're seeing just a culmination of kids who didn't have many viral illnesses over the last few years due to our enhanced precautions we've taken as a global society to limit the spread of COVID. We're seeing more kids, I think, who are both likely susceptible to get infected and then probably more likely to get slightly sicker if they are infected, just based on the principle of the second and third infection you get with flu or COVID or RSV tends to be milder than the first. So we saw a lot of kids getting infected for the first time. And when those waves of illness swept through, there were a lot more susceptible hosts to be infected and get sick for the first time. And I think that's the most likely reason why so many kids were so sick all at once.
So you're saying that because of the precautions that we took for COVID, the distancing, the masking, the staying home, there were a lot fewer kids sick the last couple of years?
Yeah, certainly the emptiest we ever saw the pediatric hospital were during the strictest times that we had enacted COVID precautions. And each time as we've eased them, we've seen rises in cases. That certainly hasn't just been the experience here in Baltimore or in America, but similar phenomena we're seeing in places like Australia and New Zealand and China and elsewhere. With easing of precautions, globally RSV and flu were really suppressed by our COVID precautions. And then as we eased them, there was more people who hadn't been infected for a few years and a number of age cohorts of 0, 1, 2-year-olds who had never been infected. And so we're a little more prone to getting infected and likely marginally more likely to get sicker when they did get infected because it was their first time.
So you and others have called this immunity debt. Can you explain what that concept is?
Yeah, it was a term that was, I think, first coined quite recently by a group of French ID faculty in an editorial, but I don't think is necessarily a unique or a new concept in the idea of infectious disease and immunology. So basically the idea of if you haven't been infected or exposed with something for a long period of time, when you finally do get infected with that thing, you're likely to get sicker. So this phenomenon is seen. Nigerian American travels back to Lagos to visit family and ends up contracting malaria. They get incredibly sick because they haven't been infected with malaria for years versus the adults in Nigeria who have been regularly infected throughout their life don't get nearly as sick. Same thing is true when someone goes on a honeymoon to Cancun and drinks water that maybe isn't as purified as they're used to, and maybe local folks are drinking the same water. The traveler gets much worse diarrhea or vomiting because their body is not used to seeing those pathogens. And just like we get a booster to keep our immune system primed and ready to go with vaccines, having the immune system more recently seen a pathogen on average usually means the immune system's more ready to fight off that pathogen. And so just that for a few years, we weren't getting sick at all. And then when the sickness comes back, that's when you have some debt to pay, so to speak.
So we're getting sicker because we haven't seen germs in a while. How could we make things better?
Great question. I think one important thing to lay out is that the existence of immunity debt does not mean that it was debt that shouldn't have been taken on. There was some debt to pay back, but that came with the benefits of multiple years of not having illness. And of course, most importantly, limiting the spread of COVID, especially before the vaccine was widely available and therapeutics were more widely available, which made the disease much more manageable like it is today compared to 2 years ago. There was no choice whether or not to employ these precautions pre-vaccine. Simply, hospitals were already being overrun despite the precautions put in place, and the counterfactual would have been catastrophic. And so I do want to emphasize that point, that just because there was this debt doesn't mean that it wasn't wise public health policy that led us to having it accrue. Now, how do we best balance things going forward? I think first and foremost come vaccines. And so when it comes to the idea of immunity debt, vaccines are a free lunch, so to speak, that you can pay back your debt without having to get sick with the illness. And so making sure we're staying up to date on our flu vaccines and COVID vaccines, but also that children are staying up to date on their routine immunizations that we know have fallen behind during the pandemic, because many of these bacterial pathogens are more prone to happen after a virus. And so making sure people are getting their pneumonia shots and other routine childhood vaccinations goes a long way in limiting how painful paying back the debt will be. And then I think going forward, it's a matter of being strategic about when we want to accrue debt, knowing that if we put in precautions that aren't sustainable long term, there's going to be some debt that we have to pay when those precautions are then lifted. But that doesn't mean we shouldn't ever put in precautions, or necessarily shouldn't be putting precautions in today. So as a society, we should be putting those in when health systems are getting overrun, because we know care for all diseases are worse when health systems are functioning way beyond their capacity. And so the principle of bending the curve when there are huge surges still is an important one. And on the more individual level, I think it makes sense to, quote unquote, accrue some debt, a debt when there's perhaps something and then maybe a transient reason why somebody is at increased risk. Say you have a big surgery coming up in 3 weeks, of course, delaying an infection until after you're recovered from the surgery is a good thing. Or say your next COVID booster is a couple weeks away. Well, maybe it would make some sense to be a little extra cautious to make sure that you delay that infection, if it is to happen, until after you've gotten that free lunch of a COVID booster, and some of those sorts of mechanisms. But realizing that if we put in precautions at a scale that aren't sustainable, there is going to be some debt to pay back in the back end once those precautions are lifted, and being mindful of that. The one specific population in pediatrics that's worth highlighting, where I think this idea still makes sense to really focus on protection, is very young infants. So we know that the first year of life, but especially the first few months of life, are the highest risk for severe disease from diseases like influenza and RSV and COVID and other just routine respiratory viruses. And so keeping babies away from people who are sick, having the family be extra cautious about spreading germs, those sorts of things are things we've always recommended, but I think are emphasizing even more now as pediatricians, as ways that we can reduce kind of the potential harm caused by these pathogens. Because even though we saw a lot more kids getting sick, and including a lot more 2 and 3 year olds in the hospital this fall than we normally see from things like RSV, if you look at the data, there's still drastically fewer 2 and 3 year olds being in the hospital than there are children in their first year of life. And that's just because in 1 and 2 more years to let the lungs mature and let the immune system mature are invaluable in terms of reducing the risk of having severe disease. And so pushing back on those initial viral infections beyond that first year of life still has a lot of public health benefit.
So in communities and societies where mask wearing is seen much more than in the United States, typically, do they find that they suffer more illnesses when they take their masks off?
So I think the debt really accrues if you do something in the short term on a large scale and then you aren't able to sustain it. So places like Japan or Korea, where mask wearing is much more common at baseline before COVID, there's an equilibrium that's in play. What we really saw this year was there was this big swing in equilibrium in the US. For example, we really took a lot of precautions for a couple of years and then really went the other way and aren't taking very many precautions anymore. And that's where you see the big swings in how things settle out. Because of course, things that are sustainable don't necessarily accrue debt, or they accrue debt that you don't necessarily have to pay back or pay back as much. So as we talked about earlier with traveler's diarrhea, all of us living in America have an immunity debt to E. coli and other infectious causes of diarrhea, but that's debt that most of us will never have to pay back. And that's a huge public health win. I think it's much easier to eliminate debt in the suppressed diseases like foodborne illnesses, waterborne illnesses, malaria, these sorts of things that are much easier on a public health level to restrict the spread of over years and decades. And so that debt never has to be repaid. Versus to date, I think it's unfortunately quite clear as of now, we don't have the tools to more permanently suppress respiratory viral pathogens at scale in terms of political will and feasibility, because it was a lot more than just masks that likely caused this huge slowdown, especially with RSV, for example, which there's data that it's less spread by airborne and more by droplet and contact. And so things like really enhanced hygiene that was practiced and surface cleaning and just decreased human interactions with school and travel and remote work are things that probably played a huge role in general. And we know some of those really painful things like missing school, not being able to go to daycare, remote work, not being able to travel and see family. And those things are much less sustainable than some things that I'm hopeful about, things like improving ventilation over time, vaccine uptake, better hand hygiene. I think currently the political will is not there for masking, but maybe in some societies. But it's really that idea of sustainable interventions being a thing to focus on, and then employing those less long-term sustainable interventions in times of need. And then, of course, making sure everyone's getting vaccinated.
Terrific. Mike Rose, thanks so much for your time.
Thank you for having me. My pleasure.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.